Next, we're going to hear from Omar Dueñas, who got his medical degree in Mexico, and then did a urogynecology fellowship at UMass, right near me. He's now at West Virginia University and director of urogynecology, and he will be talking about Biosure.
All right, so thank you. All right, so who in the group here actually uses grafts? Perfect. So, excuse me. Of course, well, just a quick refresher, right? So a graft is basically any tissue that is being implanted in the human body. And this is a biological agent. And what is different from a prosthetic agent is actually that you are not using something that is synthetic. Of course, we have multiple different types of grafts, and possibly the xenograft is the one that you don't really want to do. Isografts is almost impossible to try to find one unless you have a twin. And for sure, we only have a couple of options here, right? So we have the allografts, and also we have the autografts. In these cases, of course, a lot of us probably we use autografts, right? It's a little bit interesting, right, for all the slings and what is happening right now with the mesh. I can tell you a little bit about how I started getting involved into this. Last year, I had a chance to go to the UK, where I stayed there for a few weeks, and I was looking things around, and I can tell you how much everything has changed after they stopped using transvaginal mesh. And when you think transvaginal mesh is not only your regular transvaginal mesh for products, it's actually slings. And this is something that completely changed the way that people, they practice urogynecology, as I feel that they went back in time and they're opening patients to do purchase. Not too many people are offering laparoscopic or minimal invasive options to these patients. So I think this is something that for sure, it will be just another tool in your toolbox and something just to think about, because New Zealand, Australia kind of follow the same pathway. I hope we're not in the same pathway, but this is always something that for sure we have to start looking in the forecast and just to kind of have a couple of options. Of course, you have maybe pay attention, and there are multiple different studies out there, the controversy about the use of the grafts, and not every single graft is the same, right? Just in the same way that not all the meshes are about the same, and it took several years or maybe decades until finally they realized that we have to use a type 1 polypropylene mesh. Probably it's exactly what happened here with the grafts. As Dr. Duncan mentioned, right, so the pull-out strength for an Angusure is about 50 newtons. Here you can see that fascia lata is really strong. It's about 270 newtons. So it's probably one of those things that maybe that Angusure is going to pull out before your fascia lata is going to come up. Compared to some other grafts, we have the human dermis, and certainly using others like rectus abdominis fascia, certainly they have a little bit less pull-out strength. Just looking into the array of the fibers, I think this is again very visual. We're not pathologists, but just in the way how the fibers are being distributed for all the collagen in fascia lata, this is something that is very different compared to using dermis. And this is probably something that is different in the studies. And of course, we don't really have that perspective at this time. But I think this is the time that we have to start looking into this, and maybe it's people that have been looking into the wrong graft, and maybe it's time just to start changing that. And you're using or considering using this, maybe fascia lata is probably the best next step. A couple of the critical aspects of this is about the ECM, or the extracellular matrix, right? So it's basically, the ECM is everything that is left behind in the tissue after the cells are being flushed out. DNA, all the cytoplasm, everything that you learn in high school and also in the undergrad is being washed out until we have that ECM that is going to work as an scaffold for those fibroblasts to finally create the new tissues. A couple of things here that are different is the way that how most of the grafts are being processed. I'm not talking about autografts, I'm talking about the allografts. In this case, whatever is in the market, the majority of the grafts are actually processed using gamma rays. And everything that is put into radiation, right? If we have been taking care of patients that they suffer radiation for cancer, we know the quality of that tissue. And the same thing happens when they use the similar gamma rays to sterilize this material. And I think this is what is so different from Biosure. They use this supercritical CO2 process. Just not to be very technical, but the supercritical aspect is when a certain material, in this case the CO2, at certain pressure and certain temperature, just reaches that state that is semi-gas and also semi-liquid. And literally just flushes everything out from that ECM and dissolves literally the tissue, just leaving that ECM intact. If you think, okay, this is safe or not, well, probably if you have ever done caffeine or decaffeinated products, maybe you already were exposed to this supercritical CO2 process as they use it for decaffeination. So everything is moving out from using chemicals to now using this process in the grains of coffee. So this is something that FDA feels really safe about that. Couple of the advantages again for this type of material, of course, is good tissue preservation, intact fibers, the tensile strength, and also the stiffness. This is something that once you hydrate the tissue, you can actually feel the difference compared to some other grafts that are available. They can come in the market in two different sizes, 7x10 and 2x10. Couple of ideas and something that I actually saw out there, what people are using. Just to think about, this is actually from AUGS in 2020. This is the joint report of terminology, and actually they consider that for using grafts or using mesh for this type of repairs. And just a couple of the pictures here from this model that I have. I know that some folks are doing some sacrospinous hysteropexis, and you only use sutures. I'm just wondering what happens with that bridge that we have here. When typically they teach you how to do sacrospinous, the first rule is no bridges, right, when you're tying those sacrospinous. So it's technically impossible just to leave a bridge there because we have the distance between the cervix and those spines is about 3 to 4 centimeters. So a couple of ideas is how people, they have been doing this is something that I learned overseas and also here in the US and also in South America. People are even using mesh to do this. They call this an apical sling for hysteropexis. And for sure, probably we don't have a very robust data out there, but this is just something it could be out there for you as another tool in your toolbox, right? So we have this Biosure that is being attached to the cervix, and now you can actually reach those spines in a better way. Just for those patients that maybe they have a short vagina too, this can be a great option just to augment that tissue. For those patients that maybe they have more weakened cervical fascia, also that can be the way that you can reinforce this. Just instead of using the apical portion, you can actually stent your graft, and this can be anchored close to the bladder neck. Couple of the evidence, as I mentioned, well, the evidence is all over the place, but I think the problem is just all the studies that we have are really heterogeneous. And especially a lot of the studies that they have been done are with products that are not even longer in the market. Same material also can be used for stress urinary incontinence. I don't know who does pubovaginal slings. Yeah, perfect. All right, so, and again, right, like of course, slings, synthetic meteorital slings are really popular, but sometimes when we have those patients that they can fail or they don't want to use any mesh, what are your options, right? So you can do a birch, or you can do one of those slings. Of course, you can do an autologous rectus fascia sling. The problem that I see here sometimes is just the pain, right? The bigger the incision, also the higher chances for you to develop a hernia. So there are a couple of other ways that you can do these, and it's also harvesting your own fascia lata. But it's technically difficult. Not too many people, they have the training, and of course, it's also painful. There's actually more evidence out there for the use of these kind of grafts for stress urinary incontinence with randomized trials. So it's actually really safe, and it's something that you can offer to your patients. Other applications, this is something that is being used in gender affirmation surgery to kind of wrap around those fake corpora and the penile prosthesis, and also for the vaginal fistulas, and also for urethroplasties. So this is a material that maybe us as Eurogang, we haven't used that much, but when we start looking with our colleagues, urology, especially, they do reconstructive surgery. They use quite a bit of this material. So something, and maybe the evidence is not really robust, but because, you know, it doesn't mean that people are not doing it. And I think the idea here is just to start collecting more prospective data and kind of show how this works. A couple of things, sometimes for technicalities, right? So you're going to say, how do I get the pay, or how the patient actually, the insurance pays for this, is that you have to report when you're doing the repair that is actually a truly indication for the graft, right? In these cases, you can use this cause of incompetence or weakening of the pubovesical cervical tissue or of the rectovaginal tissue. And I think that's all that I have.